Well, good morning, good afternoon for everybody that's joined our webinar today, which is going to be focused on navigating the unique denial landscape of children's hospitals, health systems engaged in pediatric care. Before we get started and we go through the agenda, I just want to let everybody know that this is being recorded today. So there is an opportunity, of course, to review it again. And we do have a Q&A function enabled. So while we're having the discussion, if you have any questions, feel free to go ahead and submit them. We will be tracking overall, and we're very open if we think there's a question that is point on with our presenters today. We can cover that question real time. Some questions we will vet, and then we can get back to you if it's going to require specific research or we have to review it overall. But please do feel comfortable to submit questions. And with that being said, the first thing we'll do as we go through, you'll see up here as we get into introductions, and just to share with everybody that who's putting the webinar on, Aspirion. Aspirion is a company that is engaged in resolving and preventing very complex, challenging denials and other areas of the revenue cycle related to motor vehicle accident claims, workers' comp claims. But the Aspirion focus overall, like I said, is challenging and complex reimbursements to go through. And we always like to point out too, you'll see on there that, Aspirion, the organization, best in class in denials, and we take InfoSec very seriously. That's why we always put up the high trust certification to go through. With that being said, I'll cover the agenda today. Of course, very important to introduce the presenters to go through. We'll do a general overview of the denial landscape that we've seen, particularly over the last 3 years, that providers are challenged with. Then get very specific about what we would say for the providers that are relevant for this presentation, children's hospitals, health systems that are focused on pediatric care, where we can see what is the denial trends impacting those providers. And then we're going to look at how everybody's engaged in collaboration, not only in terms of getting peak denial resolution outcomes, but also how you can collaborate to prevent denials. And then we'll be covering basically where everybody's orienting themselves to use technology and tools to go through. So I'd like to go right in and get into the introduction phase here. I'm Jeff Pedraza. I'm President and General Manager, excuse me, of Aspirion's Denials Division. And I am super pleased today to have Terry Clausen and Barry Rosen with us. And I'll turn it over to you, Terry, to say hi to everybody and introduce yourself.
Okay. Hi, everybody. As Jeff said, and thank you, Jeff. And thank you, Barry, for joining me as well on this thing. And don't get confused between Barry and Terry. If we don't hear their names right, probably the other one will answer because it may sound the same. But anyway, I work at CHOC Children's Hospital of Orange County. I am Director of Revenue Cycle, so obviously I have the back end, but I also have the front end. So I have admitting and pre-reg financial counseling and the ED and all that stuff that goes along with that. I've been there 5.5 years, and I kind of have a thing for specialty hospitals. I spent a number of years, about 24 years, at a cancer hospital, not too far from Orange County as well. But I'm happy to be here this morning and share with you some of our pain points and some of our successes. So thank you very much.
And Barry, very pleased to have you. I know you're uber focused in terms of denials prevention and getting great outcomes. So I'll let you share with everybody your role today and what you're doing with the Children's Hospital that you support.
Thank you, Jeff and Terry. So I'm Barry Rosen with Children's Health System of Texas, Children's Medical Center of Dallas. We're an academic medical center. We also have a second hospital. Our mission is making life better for children. About just under 10,000 employees. I'm focused on denial prevention. I've been with Children's Health for 16 years, 6 in the revenue cycle and 10 with compliance. I have a legal background where I was general counsel for a healthcare eligibility company for 10 years, billing, follow-up, and collections, where I got into healthcare.
Yeah, great. Thanks, Barry. And like I said, for me, it's a real treat because Terry and Barry are both seasoned, experienced experts. And we're going to be focused on denials and what Terry and Barry have done with their teams to navigate, like I said, optimal outcomes and also some of the challenges with it. What I'd like to do first is just set a denials landscape. And then, like I said, we will pivot down into denials for children's hospitals. So if what Asperion's vantage point today and looking at the denial landscape going through is we always see that authorization, if you want to put denials in broad categories, authorization is the lead denial type that comes through. And what we're seeing here is just a trend setting since 2021 through there. And is there any movement just when we look at authorizations? And you can see from this, Aspirion has experienced a 10% decline in what we would say is just a blanket no authorization. Unfortunately, where we've seen the transition there is to go into basically a level of care authorization in there. And so it's really where payers are coming in and disputing that the care setting was authorized. And so this becomes more challenging when you're working with payers overall versus just saying, hey, you needed to get it authorized and you didn't, or disputing saying that didn't need to be authorized over to where a payer is going to come in and say you didn't get the appropriate level of care authorized in the phase. So this is a trend if we go to the next view here, when we look at what we're going to call out for medical necessity denials. And when you look at medical necessity denials, even though a general med nec denial is still the top category that we've seen overall, once again, we've seen an increase in what can be described as a level of care denial, approximately 20%. And what we see out in the marketplace for this is certainly related to payers disputing the inpatient level of care to go through. And so it has become more challenging from just a provider perspective, where you have to basically make sure that you're complying with payer policy overall, and that you're also, advocating for the appropriate level of care that's out there. This has been the trend overall, basically since 2020. I've been engaged in denials resolution and management for nearly a quarter century. And really the shift in this area has been a 10-year grow. And then 2020 was kind of an inflection point with it, where we saw basically the level of care continue to surface and rise as a discrete denial call out through there. We're going to pivot though, because this is, like I said, this is for all providers and what Aspirion sees in terms of big denial trends. When we switch over and we take a look at not-for-profit children's hospitals, we know there are just challenges overall in terms of operating and providing great care and then being reimbursed adequately for it. And so when we go down and we look at some of the call outs that, we've gone out and we've looked at some of these key financial drivers, we're going to boil down and we're going to look at it that the reality for children's hospitals, when we say unique payer mix, what happens for providers that specialize in pediatric care, you are going to see a shift in the payer mix. So in the next view here, we'll take a look at what we all know, and particularly if you're engaged at a children's hospital today, there's a very high ratio of Medicaid on there, where there is a minor blessing for children's hospitals because you're not going to have the same problems around MA plans, Medicare Advantage plans going through, which have been very challenging for providers across the country. But when you get into a high propensity of the payer mix being Medicaid, then for children's hospitals, that means right out of the gate that, there's going to be a heavy focus on just verifying benefits and eligibility for benefits. And so we see this too, Aspirion, in supporting children's hospitals with denials resolution. We will have a higher ratio of what best can be described as coordination of benefits is the member actually eligible for this? With that, we'll start there. Well, I know that we see a higher incident rate for children's hospitals. And Terry, I'll throw it over to you. We'll go to the next slide, and this is where we're going to start for our presenter state, talking about their denial landscape. And, I know, Terry, from your position it starts in terms of what can become a denial is making sure that that child is actually eligible. So any insights you can share into what you and your team are doing to navigate that.
Okay, thank you. I appreciate that. So first, we may as well start at the front door, right? Because we have a very high uninsured patient population. That patient population, of course, doesn't have care out in the community, so they show up in our level 1, trauma center on our ED. We do in California, we have what's called HPE, hospital presumptive eligibility. And so we, from the get-go, if they are uninsured, flag them for screening for this hospital presumptive eligibility. And that, of course, it's part of Medi-Cal or Medicaid for you all, right? And you have to meet financial criteria and residential criteria, et cetera. But it gives us, and the patient a gateway really to having healthcare after just presenting the ED. It is actually good for 2 months. So if they go from the ED and then they get admitted, then we're good on that encounter, so to speak. Our problem is we have to also have a vendor if they go inpatient to make sure that they will finish their paperwork and not just the minimal screening, because the minimal screening for HPE, assures we're going to get paid for that encounter. However, if they're long-term, anything beyond that 2 months as an inpatient, then if we don't connect them with our vendor and if they don't cooperate with our vendor, then it could be a lost dollar, revenue for us, of course, right? But we have a significantly high patient population that is on Medi-Cal, and we actually call it Medi-Cal CCS. And I don't know if you all have CCS or not, but it's a little subsection of Medi-Cal, so to speak, that provides for like chronic health conditions. So when you're admitting a NICU baby from another hospital and they're a preemie, they're likely going to have respiratory problems. So that whole prematurity of that patient is going to qualify them for CCS, which is very, very helpful, but it is the payer of last resort. But our CCS Medi-Cal population is 65%. So that's substantially higher than adult hospitals, which I believe is about 50% here. But so we end up having a very small self-pay population, right? So we have less than 1% of a self-pay population. So we get everybody who's unscheduled through the ED, hopefully on HPE, and that hopefully continues throughout their life. And then they have, as long as they keep up and finish their end of the paperwork, right, that they continue on and can have, specialty services or primary care services or what have you beyond just the hospital visit there. And that's super important to connect that, pediatric population in order to have, services for primary care. Otherwise they get lost, right?
Yeah, it's a great, it's a great call out, Terry. And I know you're sharing your perspective, sitting in California,
right,
overall, but Barry, as well too, and everybody that's joined us today, that Medicaid and is a dual regulatory scheme, federal and state regulation. And so, Terry, it's very important, I know, from any provider's vantage point, of course, to understand that dual regulatory scheme and specific to their jurisdiction. And so, California does have some unique call outs. Barry, in the state of Texas, I don't know if you want to share anything about how eligibility impacts denials for your organization today. I know in the past, we've also discussed exchange plans and like I said, the landscape that you face when you're looking at eligibility, then over to just how the benefits are aligned.
Sure, Jeff. So, our payer mix skews to Medicaid, Medicaid managed care, and commercial, more Medicaid managed care than traditional Medicaid. Going back to one of your earlier slides on the denials categories that you were seeing, we're a little bit different. I'll just mention in that, our highest denial category on pure denial reasons is additional documentation. And it's a little bit different. And we take, it's probably a quarter of our denials, preventable and non-preventable, and additional documentation. So it's a very large number. As to eligibility, we're seeing some issues between Medicaid managed care payers and the traditional Medicaid, which develops an eligibility file where there's been discrepancies between that file with what traditional Medicaid has and some of the Medicaid managed care payers, where the Medicaid managed care payer is getting information, or they say they're getting information where a patient is not eligible, and we're getting retro denials from several years ago. And we're having to appeal those and likely go through the state to get those overturned. So that is an emerging issue that occurs now and then in Texas.
So, I mean, like I said, we wanted to touch on the emphasis for everybody that we know, like I said, in a children's care setting, that we do see a bigger uptick in eligibility related denials. Then, this is not unique to children's hospitals, but because of pediatric care, we also see basically issues around high cost pharmaceuticals. And this is where, like I said, you can be, at the mercy of contract with payers overall. So, I would throw it out. Barry, we've discussed this in the past overall about, what your organization, what you've seen with high cost pharmaceuticals, the impact they have. And then I always like talking about denials prevention too, what you've done organizationally. And I know, Terry, you're not immune from high cost pharmaceuticals, and I'm always interested in, you can share too your perspective and what CHOC encounters every day in this area.
Sure. So, probably 5 years ago, when the high cost drugs were not at the level they are today, the organization started implementing a high cost drug policy where those are identified on the front end, and that list changes as time goes by. Then the organization has deployed a central authorization department, which every high cost drug, actually it's every medication based on a therapy plan, whether it's OR, interventional radiology, or ambulatory, if it's identified in that therapy plan, then that central authorization department verifies benefits, which is important, and their medication, and obtains the authorization with the emphasis on what the site of service was approved. In the past, there was opportunities with the white bagging and specialty pharmacy, and we really essentially eliminated that through this process that we've deployed, where we're checking upfront based on that plan of care, and then making sure we're not just accepting if they say no authorization is needed. We have a specialized team that verifies what that site of service is, not just that the patient has the benefit or whatever the drug is, but that the benefit is approved for where we're giving it, to eliminate that denial.
Yeah, so we can expand a little bit when we just talk about, we have a call out here to talk about collaboration and what it takes, and you're already hinting on what your organization has done, not just from, a post-discharge denial landscape, but to move forward in the scheme. And like I said, to collaborate, with others throughout the organization. That goes into even one, like I said, to make sure you're very focused when we talk about high cost pharmaceuticals and what is approved, how many units get approved to go through, but to address that even upfront in terms of, even before you have a patient come to the hospital, but then when you have a patient in-house, to make sure that you're going peer-to-peer and you're specifically getting that approved. So, and for, anybody who's joining today, like I said, you can submit a question. Barry's got some really good detail about what his organization did really to mitigate this type of denial overall, and to capture, all reimbursement dollars for that needed care, that was provided. Terry, we've discussed this a little bit, but I mean, from your perspective at CHOC, would you say this is an opportunity right now for CHOC in terms of high cost pharmaceuticals? But what do you experience in here, and how is your team addressing it?
Yeah, well, I would say one thing. Well, having been very impressed by that when we had, a pre-call with Barry, and having, I think they really have it nailed. And that's one thing we absolutely do not have nailed, right? And so our authorizations team does not, unfortunately, fall under me except for the hospital. But, we have, 22 hospital-based clinics, and those teams are scheduling the doctor's visit and the infusion visit, right? So they are the ones that are responsible for getting the authorization for that outpatient drug. And so we don't allow white bagging or brown bagging, but that team was under the impression that they could order a buy and bill when there's already been a denial for that drug. And that we would somehow bill and get paid. And so we had to provide some education for that as well. But the thing that we're most frustrated with as a children's hospital is that our outpatient drugs are being referred to a specialty pharmacy, CVS, as a matter of fact. I think I can probably say that, right? Because a lot of people are getting referred to CVS. But most of those drugs are not given to patients at CVS. They don't service them. Right. And then so the team goes ahead and orders, the drug, the buy and bill, and they were under the impression that we were going to bill the payer or the parent and get paid, and that is not the case. So that's one thing, really developed. We just started recently a high cost drug team, and we really initially started it for denials on the inpatient side. But then having all of these specialty pharmacy denials, and the service still provided us was really getting to be problematic for us. There is a mechanism for them to communicate back to the payer, regarding that they don't provide this drug for pediatric patients, et cetera. But that never seems to be happening on their side, because again, I don't see those denials until they have been worked and denied, or we've escalated them and sent them to, our specialty denial, worst case scenarios to, for you all to work, right? So we haven't been very successful in getting that overturned either. But I do want to just pivot 1 second to the inpatient denials, if we may.
Sure.
And they're not, the patient was a NICU baby. They've come in for respiratory, right? Because they're preemies. They're going to get nitric, right? And that's very, very costly. And the payer policies are very, very strict on that. And Barry, you can help me if you recall. It's 35 gestational weeks the baby has to be. And they can only do it, is it 4 days or 5 days? I forget, but it's a very short period of time. It's either they get better from it and they respond, or they don't. So we missed the boat a lot. The physicians missed the boat, and they prescribe the nitric, and they'll go on and on and on, because that's the only chance really for the baby. And guess what? It's a denial, right? The other thing is it's a carve out on the inpatient side to go beyond that. And we don't, somehow the inpatient pharmacy and case management don't connect on, now we're going beyond, outside of that policy, can we get an exception? And none of that happens. So we have just recently developed this high cost drug team for inpatient and outpatient, but we have a long way to go. There's no doubt about it, because that's not the only one that's getting denied.
Terry, the first way to fix a problem is to identify all the factors, and like you just went through the continuum. And Barry, I know that, like I said, this is an area that, you know, you've specifically focused on. I don't know if you wanted to add anything else.
Sure.
Terry was talking about it.
Yeah. So on the inpatient side with the nitric oxide, you know, the payer policies are pretty consistent. I think it's 34 weeks of gestation, sometimes with a cardiac type of hypertension, heart disease, hypertensive crisis diagnosis in there. And, you know, it's a supply item. And what we've done is we have certain payers that through the process receive medical records. And then those payers, when they see in the medical records that there's nitric oxide, they issue a concurrent denial. When that occurs, then through our department, then there's some type of expedited concurrent appeal that's done. And what we frequently see, and we've been very successful on those, and what we see frequently is when the payer has the policy that they're not even applying their own policy, especially with the cardiac type of diagnoses, where they can easily see that the patient is there with a cardiac diagnosis, meets the gestational requirement, is still denying it. So that gets pointed out, and we've been pretty successful in getting those not denied before the first denial comes in. You know, we don't want to manage a denial. We'd rather prevent the denial. That's the name of the game, to speed up the efficiency of revenue cycle and get that appropriate monies in as efficiently as possible. So, you know, I don't see the level of nitric oxide inpatient denials in 2024 or 2023 as I saw, you know, 2022, 2018, that time frame. We used to see quite a lot of it, and we really don't anymore. Still see a few that don't go through the process, but nothing like it used to be. Been a very successful effort on that topic.
So, you know, Barry, you're going to be our go-to source when people interact with us, like I said, because it is a good, not just story, but how you executed around this. And so just, you know, it's a really good call out when we talk about collaboration and what it takes. Well, I'm going to kind of go back to just overall denial trends. And so, you know, Terry, you had shared with me that you've got a major payer that you have a pretty high denial first pass incident rate with. And we're not naming names, but it's really about what you're experiencing there in terms of why the rate's so high, what it's linked to overall, and then what you and the team are doing to navigate that. You know, because we're certainly getting some questions in here around you know, authorizations, the electronic process, in terms of like, hey, you know, how are we actually taking the steps so we can prevent stuff that we would tag into an auth related denial. So I'll turn it over to you just to share with what you know your exposure has been, and then all the tactics that you take to address it.
Okay, great. So we have, and I won't name payers, but it's commercial and it's government. But recently we found out that we had an 80% first pass denial rate. And it wasn't necessarily for authorization at all. It was, it could have been something, you know, super simple, like they're wanting medical records. It's more like payer delays, so to speak, right? But we have a ton of those, 80% of that, right? When we bill our government payer, as an example, you know, we are, for Orange County, we're 100% managed Medicaid, right? And we have about 8 managed plans, as an example, right? But so part of the claim goes to the medical group, part of the claim goes to the government side, correct? And the government side was denying them for one item, and it should probably be an inclusive, it's acetaminophen. So we're having 636 drug denials. And so that's literally every single patient that comes into the ED is probably going to get acetaminophen, right? And so that's where we learned it first, but we weren't realizing how quickly that denial was happening until our analytics tool was able to prove it to us, right? So that was one trick that was happening. And then we have a payer, a commercial payer, who is automatically denying every claim that came in that was 50 grand or above. And in a children's hospital, you know, that's pretty much any inpatient encounter that you have, right? And so we had to figure out why they were denying it. There was no legit reason. Again, they're asking for medical records. So it's more like a delay in payment, right? But it's a lot of work on our side, right? And if you can't measure it, you can't monitor it, right? And so thank goodness that our analytics tool provider was able to share some of that information with us. Otherwise, it takes a long time. You know, your patients don't line up together, right? Your payers don't line up together. You just got all these claims, right? So we're really grateful to have that tool in there to help us realize that. I mean, it was really quite a shock to us to find out about this, but it did allow us to go, you know, to the Joint Operations Committee and take this to them and say, okay, this is absolutely ridiculous, because they would deny it. They would send it to the medical group. The medical group then had, you know, the acetaminophen in it, and they're denying it and then sending it back to that. So you'd have 3 denials on the books for one encounter for, you know, something you're literally going to get pennies on from the government for that acetaminophen. So right now we're trying to reverse that by using a different code on it, which is working for the commercial payers, but we're still waiting till the end of the month to determine whether that's good enough for the government.
Yeah. So Terry, some of what you touched on overall, when it's just about, you know, providing information, payers requesting certain stuff. You know, in the Q&A, we got a question that is somewhat linked to this overall about, you know, the upfront process and then, you know, validating the appropriateness of care. I'll just read part of the question. It's like, do you see a light at the end of the tunnel as it relates to electronic prior authorizations going through? And so, you know, Terry and Barry kind of share, you know, the auth process, because the person that submitted the question is like saying that there's difficulty, you know, always having to provide the burden of proof is on you that you sent timely information. And when you sent it, say, you know, I think it would be helpful to touch on how you're addressing that phase too, around the prior authorizations. And then even to the point of what are you doing in terms of providing the necessary information that payers are requesting, or where you would dispute that they need the information.
Well, it's a good point about, do they need the information? Going back to the documentation request Terry mentioned, it's our single largest category, and it is a dilatory tactic because we know that ultimately almost all of that is paid, because they don't turn into final write-offs when they deny for that initially. So it is a dilatory tactic. We've not been successful in getting it stopped by showing that they ultimately pay it. We're working on some different things with payers. There's some tools that we're evaluating to send records more quickly, depending on whether the payer ingests that information before they issue the denial, would determine whether they're going to mitigate that initial denial or not. But we're still on that journey. One of the things that we did to figure some of this out is we set up our own dedicated analytics team within revenue cycle. You know, within that team, you know, it's our job to do the analytics, not anybody else's. You know, the analysts that we have, you know, they have deep patient financial service experience, in many cases 15 years plus. They're knowledgeable on the billing regulations and payer policies. They've worked at pediatric hospitals over their careers. They have a long history with the same payers, and they know what's happened before. You know, we have a registered nurse on our team that can help with some of the clinical things when that comes up. You know, we're seeing a lot of the same things. You know, one of the things we're seeing on authorizations is, you know, our process here is whenever that is done, whenever we make the authorization request, all of that information goes into, I think the system's called Trace, and it can be recalled very quickly to prove when things were done. So we usually don't have a problem with proving when something was done. But what we do see some opportunities on with certain payers and some of their external vendors, and I'll just mention the vendors, Carillon and Quantum, where the payers are using those vendors for authorizations. The vendor is giving us the authorization, but the vendor system does not seem to be interfacing with the payer system on the authorization. So even though we have the authorization, then when we submit it to the payer, we get some type of no authorization denial, which then we have to go back and prove that we actually did have it. We have discussions going on in our joint operation committees with some of those payers right now on the topic, but it is, it's an opportunity. And one of the things that we're seeing is when when a payer has a vendor involved, it's, they point the finger at each other for a long time before somebody owns it. And then it takes quite a long time to actually solve the issue. And that's an opportunity in itself when we're dealing with vendors on behalf of payers in the authorization space.
So Barry, what's and of course you've oriented this appropriately, where like you said, you have a vendor that's, a payer is utilizing, in the auth phase of it. What's the initial payer feedback that you get rather than the case-by-case feedback where you're trying to say, no, the auth was actually granted? What's the initial payer feedback you get when you're like,
well, the initial payer feedback is we didn't have an auth, and that's the problem when we did, because they're not getting the information from their own vendor appropriately. So
yeah,
then
no,
we have to,
when
so then we have to go prove
globalize it,
everything.
yeah, when you've globalized this now with payers, I'm interested in when you've approached payers, like saying that you've got a systematic failure going on here. I was just curious. I mean, what's the initial position that payers take on it?
One, it's not their problem because they're doing it correctly. And even when like I said, we're still working through that, Jeff, in that we haven't solved the problem. And it's a problem between the payer and their vendor. And it's not solved completely at this point. And we're seeing it with different vendors for different payers. And it causes real slowdown, an increase in denials and AR days and things that ultimately would be paid for. And it burns a lot of organizational resources between managed care having to raise it with payers when it shouldn't be a problem at all. I mean, it just abrades providers.
Agreed.
I wish I had a better answer for you than
no,
we're in process, but that's where we're at.
Yeah, I knew. I mean, I live and breathe this stuff, all the time. And like I said, I know what the position payers normally take, overall, that they're in compliance with it. But like I said, anytime you bring in yet another, a third party or vendor to the process, on there, you want to hold, ultimately it's the payer's responsibility, for reimbursement. So you want to hold their feet to the fire to go through there. Terry, in this area around authorizations, is there anything, when Barry's covering this, do you encounter similar things, or do you feel like just from an auth standpoint, that, even though you may encounter problems on there, that you have a pretty clear line of sight?
Yeah, well, I think we get the same kind of denials that Barry was talking about, that it's no authorization, it was missing authorization, and it's sitting there in the system somewhere, and we find it and resubmit the paper copy. We might have had the number, that, spits out on the claim, but then they're wanting, hardcore evidence that there was, a legitimate paper authorization, admitted to. So it's the same thing. We don't have this team like Barry has for that, and we don't have an authorization vendor per se. We do radiology through AIM, et cetera, but we take care of it, ourselves. And we also have other where we have gotten authorization, for example, as an inpatient stay, and then we'll get a denial because they downgraded to observation, and then we didn't change the observation we didn't change, get a new authorization for the observation versus the inpatient on the same encounter. So we have a lot of that as well too. But the other thing is, I wanted to backtrack for 1 second here. When we were talking about, you know, these payer delays for whatever that they're wanting, right? If we have found that if we send something certified mail, boy, they never got it, for goodness sakes, right? Or it went to a mail room who was one of their vendors, right? Because they took their portal down, and that mail room is taking 60 days to upload it into their system. And that has been a huge issue for it. So we did have to get managed care involved and have a come to Jesus with them, with this particular payer. But it was our top, payer. And so we have rectified that since. And the other thing that we have done is that we are anticipating what they're going to say, you know, what kind of, that we're going to get this denial because they're going to want medical records because it was over that 50K, for example, right? And so we are automatically uploading with our claim, if they have a payer portal, that we're actually uploading those documents, those medical records at the same time. So hopefully that will turn it around and we'll see a reduction in days and a reduction in denials based on that. But that whole game that they're playing with asking for medical records for simple $50,000 claims, right? That's what that's really doing to us, besides the extra work, is it's taking our days in AR and shooting them up. And that's problematic for our CFO. She'd like those to come down.
Yeah, Terry, you touched on something that just jogged my memory, and I didn't think I'd ever bring up mailbox rules and stuff. You know, the presumption that when, you know, the United States Post Office is considered in courts of law as a very reliable means of, you know, moving information. So there are mailbox rules that are out there, and it's, you know, it does frustrate me, you know, from my vantage point, my team's vantage point, when you have to clearly demonstrate to payers that information was submitted on there, like to go through, you know, the process of actually and the expense of certifying to go through. But I mean, just mailbox rules, period. I've routinely in my career had to lay that out to payers that, you know, the position they're taking has no merit whatsoever. To go through on, you know, with the time we have left here, and we were talking about collaboration. Barry, you touched on something that I'm going to use the segue just into tech, you know, to go through that. When you said that it's your team's responsibility to engage in analysis, to understand everything, not to wait for somebody else in a different department to come to you. Can you share a little bit just about the framework of your analytics team, outside of, you already mentioned some resources, how you're actually doing it internal? And then Terry, we can shift over to you about how you know, you're approaching it well too, you know, from an analytical capability standpoint.
Sure. So we download all of the claim payment data from our EMR, which is Epic, into Tableau, which is now owned by Salesforce. And then we analyze the data on the HB side and PB side, and we're looking at denial categories and remit codes, and we're drilling down into those, and then going into the CPT and supply levels, depending on what they are, based on dollars volume. And we're identifying those trends. We're looking at higher dollar initial denials on the HB side weekly and trending those to see if we see new things occurring. But in looking at the CPT codes, then we're also looking at diagnosis codes. We're exploring artificial intelligence to see, with our data set, what we can do with looking at which combinations of diagnosis codes will pay with our pain, with different procedure codes, supply items. So that's something we're evaluating right now. I don't know if I answered your question or not.
No, it's about one internally, when when I asked the framework, absolutely, meaning that how you've built the system, and then the reasoning and where you're going with it as well too. And that's why I said that analytics, big data, it just can't be done for its own sake. And I know, like you've shared, like you said, where you're going, and we get a lot of questions on the Asperian end around tech, overall, that AI as a term certainly has a lot of hype in the industry. But we always like to break it down, because I know that when I wanted to start with data and analytics, and how systems can approach it. Either we can build our own internal capabilities using a system ourselves and getting team members put to it, which, Barry, you've been very good at breaking down in discussions about how your organization and how you're leading this effort to do it. And then Terry, you're, at CHOC, you're in a position overall that is also very common, that you go out and you're like, how can we also have top level analytical function? So, I think you had a pretty good take on how you can take an analytical platform and then also maybe drive it to empower other systems that you're using today on
Right.
there.
Exactly. Yeah. And so, yeah, we don't have it internal. We don't have that internal team that Barry has. Our analytics team does crazy other things. And they're not really focusing on the revenue cycle, right? They work for the revenue cycle, but that's really not the kind of data that they're doing for us. So this analytics vendor that I have, I guess I can say, if you don't mind me saying, it's Visiquate, right? And, every little thing that happens, and we're on Cerner, Millennium, and everything that happens in Cerner transfers right over at midnight to our analytics thing, right? And sometimes you can just get too much information, right? I need to like narrow it down. There's a bot by the name of Anna, and I can ask Anna questions, etc. She doesn't always understand what I'm asking. It may give me a whole host of other information that I didn't necessarily need. So I do believe that you need to have, I think we need an internal analytics team to work just in our analytics tool, right? Because I have a lot of reports that come to me, but then I still have to download them. There's still a lot of work, etc. Right? But it's information I wouldn't have otherwise, right? It is the information, and then they're now looking at it too. I'm like, this takes a lot of work for me or my managers or my VP to look, at these reports and figure out, even though they met the criteria of the report, right, for denials or for specific CPTs, specific payers, specific denial reason, all of that happens in that tool. But I'd like a little dashboard that just tells me kind of what to do. So I need some minions really there working in that tool. So recently we've just hired a new denial supervisor, because we worked all of those denials within the internal follow-up team. And so I've hired a new person, and he gets to hire his own team to work solely in our analytics tool. And I think that we'll be able to go much further with it, kind of like Barry's team does, right? Because there are employees and we can direct them what to do, but we have all that, like the information that they download into Tableau. So I think it's going to be helpful.
I would add that one of the critical things our analysts do is we don't accept what that initial denial that the payer says, whatever the reason they give us is. Frequently we find out it's wrong, it's incomplete, it doesn't make sense, it's internally inconsistent. They're doing the same thing differently on the same types of patients. So what the analysts do in my area is, when they're looking at those initial denials, they're looking at those remit codes. They're reclassifying each remit code, when we can see a pattern as a root cause in our EMR. And that way, by getting it to the correct root cause, then it makes it simpler to analyze what's actually going on. What we found in the past is if you go off only what the payer is saying, and then you go to your providers and you asking doctors to look at data, then they get abraded when things aren't really what the payer says. So we have to reclassify that, by root cause to get a better understanding of what's actually happening. And that's a very key thing to do to analyze these denials in the front end to mitigate them. Because if you don't know what the animal is, it's hard to capture it.
Yeah. And so, I mean, Terry and Barry, you both are touching on a thing. That's why I wanted to start with uh, data and analytics, is that there's different tools you can use overall, but then it always gets to the part of what is actionable. That's what I meant. Just doing data and analytics for its own sake, you can really throw out tons of cool dashboards, but then it is like you're both on, a continuous journey on what's going to be actionable. What are we identifying? And, Barry, you do a great call out, because if you're dependent just on payers, CARC and RARC codes, you're going to have a very generalized view of your denial landscape overall. And it is in, my experience, and I recommend to, every system that we work with, is to start to define root cause on everything. And that's where you can then lead to actionable intelligence. I mean, on the Aspiring end, we have 14 different root causes for an authorization denial to go through. We have definitely a big top three in there, but we want to be very specific as well too, because then you can start doing, like I said, actionable plans once you identify it. Terry, I'll segue a little bit into, I think you discussed before in terms of your front end process about how, you have to go out to try to deploy technology to actually get something, a tool you're already using to work, and so if you want to share a little bit of the story, and you don't have to name names, but just what you looked at and saying, we need to optimize this.
Right. Yeah. So thank you for that, because I'm super excited about it, because we're not live yet. We're going to be live in about 3 weeks, but we're actually using our analytics vendor to automate eligibility. And so they have some bots, right? And we just finally had a demo yesterday of the bots. So every time that an encounter is scheduled, so at the get-go, right? So every time an encounter is scheduled, the bot is going to see it within 5 minutes. So it's going to work very hard all day long, every day of the year, right? And there's multiple bots. And so this SIU scheduling interface is going to come to them, and they're going to take what is in the system already in the insurance plans, and they're going to run eligibility through our regular eligibility vendor and see what comes back. And so when that comes back, if it's different, they're going to update the system. If it's flawed and there is no eligibility, it goes to a work list to whoever scheduled that appointment, because technically they're supposed to schedule reg, right? But you got to, I mean, why are you scheduling an appointment if that patient doesn't have the insurance that's in the system? You got to get it fixed, because you can get an authorization for for a payer that's no longer, eligible, that this patient has in the system, and it's no longer eligible. And the reason that we're doing this is because, so I control the facility side, but like I said, we have all these hospital-based clinics, and then we have primary clinics offsite, tons of them, right? And they like to kind of do their own thing, and they don't answer to me, but they'll just move forward the insurance from the last time the patient was here and not run eligibility, right? And even though we have an eligibility tool for them to do, which is embedded in Cerner, we also have a registration quality tool that they're supposed to look at the end of every day, and it's got your errors, you're supposed to fix them. Well, we found that they're not doing that either. So I don't want to have all these denials, whether they're hospital or they're pro fee. So we've engaged with them to automate this. And the other thing is to scan the eligibility, because even when they're running it, they're not doing anything with that piece of eligibility, and the eligibility only remains in on the eligibility site for a period of months, right? So if you have to go back for a denial to say it was there and it's not there because somebody else has put a new insurance in, then you just wasted a whole lot of time. So this tool will actually, screenshot that eligibility and put it into our images for that encounter. And so we're told it's going to be an 80% reduction in eligibility denials. So I'm super excited about it.
I would be excited too, even if
I'll believe it when it happens.
I was going to say, even if you realize half of that, you know what I mean, or 25%, it's still well worth it. Well, we can shift it, because what we're talking about now, I wanted to set, for our final minutes together, to kind of talk about the tools you're using, starting with, data and analytics. we have a view right here. I mean, on the next view, when we kind of look at what we call the evolution of technology adoption, I think that, Terry, you got a great example of where you are driving right now. If we start over at the left when we talk about eligibility. And so you've got a great example of we need to use tech to actually get the tech we have optimized today to go through. And so, Barry, when we look at this right here, there is a big difference when there's a lot of buzzwords thrown out about, like I said, the tech tools that are being used, meaning versus automation versus going in and using AI to go through. I mean, if you've shared before about how you're approaching some automation that could then lead to maybe use cases to start, I'll put AI as a big umbrella out there to talk about machine learning and large language models.
Yeah. And
Sure.
we have exactly 4 AI vendors outside of our analytics tool doing different things for the facility side and for the prophy side as well. And it's proven so valuable for, small things that you need to do to clean up your AR, right? These denials that are never going to get paid for the acetaminophen, right? Because those dollars stay on there, right? And nobody is going in and messing around with, a balance of $3 and writing that off, but you have to get it off your AR somehow, right? And so we're using AI vendors to perform that work for us too, which takes a lot of the burden off of the teams putting together lists, et cetera. So that's something I'm super pleased with too. I love AI. If we, I mean, the vendors, the payers have been using it for a long time, and that's how they're, there's one big healthcare company that is denying in their protocol, it's 50% of the claims that come to it are automatically denied, and they're using AI to do that. So we've got to beat them at their own game, so to speak.
Yeah, I mean, on the payer side, that there's always been a very algorithmic approach to, one, trying to gauge the appropriate level of care that providers are administering, and then also, how they're going to pay for that care. It's always been very algorithmic. From my vantage point, the payer side of this equation has certainly embraced it just to do their risk management job overall. And, Terry, like I said, when we say AI, there is a difference, in terms of what's really machine learning versus running bots, for instance, and automation. And so, like I said, in the closing minute here, Barry, I think you could probably touch on automation efforts versus now what you're looking at for AI deployment as well.
Yeah, in the automation, we've done many of the things that Terry has mentioned. Within our EMR platform, it can do a lot of those things in terms of closing small balance, small dollar types of things where it doesn't take human intervention. And there's who knows how many of them are out there. But we've done those things. Those things have been deployed. We're looking at a vendor evaluating artificial intelligence for basis of appeal letters, things of that nature. One of the things that one of the opportunities that we're seeing, say opportunity, it's a problem. We have certain payers that do what I call slice and dice audits, line item denials on inpatient accounts for billing methodology. And we're trying to get our hands around that. It's a growing issue where you have things like respiratory therapy denied, oxygen, point of care labs, things of that nature based on payer policy. And it's their straight up way of transferring, our margin to theirs. There's no medical necessity reason for it other than they don't want to pay for it. It's a legitimate cost to the organization. They're not saying it's not necessary. They're just saying we don't want to pay for it. How to fight that type of battle, especially with the commercial payers.
So we're at time, and talking about what I'll broadly label as tech and, AI, we could have a whole other session about each use case and how your respective organizations are approaching it. But I do know in working, with you and speaking with you, that both of you have been engaged in what I call the continuum of let's analyze and then let's look at every tool available to optimize our results. But the biggest thing is I wanted to say thank you. Earlier, when we did our prep, everybody was worried, are we going to be able to talk the whole time? I told you, we will squeeze every second of this out overall. I couldn't be more pleased that, you both said that you would share your insights. For everybody that joined us today, like I said, you can scan overall, get information. We had some questions come in. Some of those we're going to specifically look at. And we're always happy. Everybody's very busy. But we're always happy to connect people as well too that are focused on solving some of the problems that we covered today. So once again, a really big thank you to Barry, a really big thank you to Terry, and for everybody that's joined us today.
It's been our pleasure.
Thank you.
Thanks, guys.